Hello everyone, this is I will teach you medicine. Today we are going to study about obstetrics and gynecology, and in this is a very practical topic. This is very important. So before you go in the ward and practice it by yourself, you have to know the theory. Okay, so this is the note I have prepared for the methods of the obstetrical examination. So what are the prerequisites for obstetrical examination? Okay, for any examination you have to know this is like concept. Okay, NICE. So you have to namaste the patient, you have to greet them, you have to introduce who you are, okay, and then you have to tell them what you are going to do to them. All right, so introduction, and then you have to let them know what are the examination, what will be the parts of the examination, what they should be expecting while you are conducting the examination and all. Okay, and then consent, you have to ask for the consent if you can proceed with your examination, and then the main part of the examination comes. All right, so what are the prerequisites, other prerequisites? So you have to ask the patient if the patient has evacuated the bladder or not. Okay, so if the patient have not evacuated the bladder, then the uterine, the uterus could be pushed anteriorly by the bladder. Okay, so that is one thing. And then you have to sit on the right side of the patient, and then you have to put curtains for the privacy, and then you have to keep the patient in a comfortable position, and the more the position which you will be putting is dorsal supine position. All right, and then you have to ask for a attendant or a chaperone, female attendant, and then you have to do the proper exposure from sternum to pubic symphysis. Okay, sternum to pubic symphysis, and then you have to do the sanitization of the hand. Okay, so that is that comes under the prerequisites. Okay, so you will have to do that, and then you have to proceed towards the inspection. So you have to note if the uterus is ovoid. Okay, uterine ovoid is like what type of ovoid is it? Is it transverse, or is it oblique? Um, this uterine ovoid. Okay, is it like more like transverse, or more like oblique, or more longitudinal, or something like that? I'm very bad with the like picture, so please, I hope you are getting this. All right, then you have to see the contour of the uterus. Okay, if there is any fundal notching, at the site of the fundus, if there is any notching, if there is any convex or flattened anterior wall, or any kind of cylindrical or spherical shape, you have to inspect that. And then you have to look for any signs of like undue enlargement of the uterus, and also you have to comment on the skin condition of the abdomen, and you have to see for the evidence of the ringworm or scabies, or any kind of hyperpigmentation, linea nigra, stria gravidarum, etc. So also you have to check for the incisional marks on the abdomen. So that these consist of inspection. So now we proceed towards the palpation. So palpate, so how should we palpate the patient? So first thing is height of the uterus. So the uterus is to be centralized. Okay, if the uterus is slightly rotated, to the left, then you have to centralize the uterus. Okay, and then what we do, we have to take a measuring tape, and that is very essential to measure a height. Okay, that is symphysiofundal, from the pubic symphysis to the fundal height. So there are 2 points while measuring the symphysiofundal height. Symphysio means symphysis. Okay, pubic symphysis, that's a bony point, so that is a stable point, whereas fundal is an unstable point. All right, so now what do we do? The ulnar border of the left hand, of the examiner, is to be placed on the most uppermost level of the fundus, and it is marked. You have to place your ulnar border on the uppermost level of the fundus, and then we have to mark it. And then we have to uh, while measuring with the measuring tape, we have to turn it to the inches side. Okay, so the measurement should be taken in inch. Okay, and then converted into centimeters. Okay, so why do we do this? So it is to neglect a bias. Okay, so we can suppose we know a patient that has come, with the 32 weeks of period of gestation, then we can already know. All right, so we will lie to our ourselves. You will force that yes, it is 32 centimeter, but no, that's not the case. So in order to neglect that bias, so I hope you understand that. So we have to take the measurement in inches and then convert it to centimeters. So this is not done with the knees placed. We have to, while measuring, we have to keep the legs straight. Okay, so gestational week corresponds to the symphysiofundal height. Okay, if it is 25 week, then it is like 25 centimeter, 31, 31, and 31, 36, 36. Okay, so this is the depreciation, So this is a normal tom abdomen, tom baby. So we have to see, okay, 12 weeks it has the pubic symphysis. Okay, here is the pubic symphysis, so it is 12 weeks if the uterus is at there. And then at 22 weeks or 24 weeks, it is at the umbilicus, and at the 36 weeks, it is at the G sternum. These values are like variable according to books. I have seen some 2 to 3 books, and some of them were like little bit up and down, but you have to get this idea. Okay, 24 to 12, 24, and then 36. So at 12 weeks, fundus just above the pubic bone, and then at 36 to 38 weeks, fundus under the right sternum. Okay, right sternum, and at the 40 weeks, at term, the fundus slightly goes down. Okay, as the 40 weeks, the fundus slightly goes down. Because why? Because it goes like this. Okay, presenting part drops down into the pelvis. Okay, this is the real pelvis. Not this is the pelvis. So first it was like this, then after it hits the 40 weeks, so it like slightly descends downward. Okay, so we can find this. Okay, 40 weeks. So what are the conditions when the height of the uterus may not correspond to the uh, period of amenorrhea, or pregnancy? So height of the uterus may not correspond to the period of pregnancy. That is due to the mistake date of last menstrual period. If someone doesn't know basic math and they mistake the date, for calculating the last menstrual period, that then we can have the condition where it does not correspond. Okay, height does not correspond with the period of amenorrhea. Another is twins. Okay, there is a big baby, there are two babies, and then we have polyhydramnios. There is a lot of fluids. And then if the baby is big, and if there is any kind of pelvic tumor, it can be either of the ovarian or the uterus origin, or fibroid. And if there is a presence of hydatiform mole, and then there is a concealed antepartum hemorrhage or something like that, any kind of hemorrhage. Okay, so these are the conditions. This is a very important viva question. So these are the conditions where the height of the uterus may not correspond to the period of amenorrhea or gestation. All right. So what are the other conditions? Conditions where the height of the uterus is less than the period of amenorrhea. Again, it is the less. Okay, it is less, which may not correspond. This does not correspond, and this is the less. So that is mistaken date for the LMP. And then if there is a scanty liquor amni, and then if there is the baby, there is a fetal growth retardation. If there is no growth of the baby due to various factors. So fetal growth, if the fetus is not growing properly inside the womb, so that can also so the less reading than the actual period of gestation. And if there is a intrauterine fetal death, IUFD, so that is it. So now moving on towards the obstetric grips. Okay, it is also known as the Leopold maneuver. Okay, so obstetric grips, you are going to grip the abdomen of the patient. Okay, so you are going to do that. So for that we need to flex the knees, and then first Leopold. Okay, so we are going to do the first Leopold maneuver. So there is fundal grip. It is also called as a fundal grip. So palpation is done. We have to face the patient. Okay, see how this I have also kept gif for this. So this patient is facing towards the patient. Okay, so this examiner is facing towards the patient. So whole of the fundal area is palpated using the both hands. See how she is using like both her hands. Fundus is palpated. So and we have to find out which pole of the pole of the fetus is lying into the fundus. Okay, which pole of the fetus is lying into the fundus. So if it is broad, soft and irregular mass, then it is suggestive of breach in the fundal grip. Okay, and if it is smooth, hard and globular mass on palpation, then it can be suggestive of head. Okay, so none of the fetal poles are palpated in the fundal area. So that's there. So this is the first maneuver. Okay, first Leopold maneuver or fundal grip. And then in the second Leopold maneuver, that is a lateral or umbilical grip. So palpation is done. Again the examiner faces the patient's head. Okay, face, and then hands are placed flat on either side of the umbilicus. Okay, so here is the umbilicus, one hand is placed flat and another is like palpate. Okay, that is the palpatory hand. So we have to like push, one is fixed and another hand, see how she pushes. All right, so we have to do that. And then we can find it like it is drawn on both right and left side of the patient, and we can find the position of the back. Okay, and we can also find the position of the limbs and then the shoulder, etc. So what it says here, palmar surface of one hand is used and one hand is kept in lateral, while the palmar surface of the other hand palpates. Same thing what I have said. Okay, so the back is suggested. So how do we feel if it is a back, or or limbs, or any kind of like shoulder? So if the back is suggested by a smooth, curved and resistant feel. Okay, so while doing, like, while we are palpating, there is a smooth but curved, okay, and resistant feel. So that is the back, on which side it is. Okay, left or right. And then the limb side is comparatively empty, and there are like small knob like irregular part. Okay, so that is the mm, uh, parts of the limb. All right. And then, so we have to, after that identification of the back, then it is we should like know where the back is. It is either anteriorly or towards the flank. We have to know that. So, and the third, we move on to the pelvic grip, or also known as third Leopold. Okay, so again, this Leopold maneuver is done facing the patient's face. Okay, so the you know outstretched thumb, look at her thumb, outstretched thumb and the four fingers of the right hand, of the examiner, are placed over the lower pole of the uterus. This is the lower pole of the uterus. And then keeping the ulnar border of the palm of the upper surfaces of the pubic symphysis. You have to keep the ulnar border at the pubic symphysis, and we have to look for the lower pole of the uterus. Okay, so when the finger and the thumb are approximated, and the presenting part is grasped, it is grasped. Okay, if it is not grasped, then it is if not engaged. Okay, if it is not engaged, then you can grasp it. Okay, also for the mobility of the side to side. Okay, if the head is free, then it is palatable, but pelvic grip is empty, that is in the, if the baby is in the transverse line. So you have to know that. No, so now let's move on to the pelvic grip, also known as fourth Leopold. Okay, so this is the only Leopold maneuver that is done by facing the patient's feet. Okay, so here the four fingers of both hand are placed on either side of the midline in the lower pole of the uterus and parallel to the inguinal ligament. So both hands, they are kept parallel to the lower pole of the uterus and parallel to the inguinal ligament. And then the fingers are pressed, the finger are pressed downward and backward in the manner of approximation of the fingertips to palpate the part of occupying the lower pole of the uterus. So we have to press down, backward and downward, so we can palpate the part which is occupying the lower pole of the uterus, that is presentation. So if it is converging, then the head is not engaged. Okay, if it is diverging, converge boy when I say, it is not engaged. Okay, so if it is diverged, then the head has engaged and already went up to the pelvic part. So we can know that by the fourth Leopold. Okay? It is also known as pelvic grip. All right, so now moving on, we move for the palpation of for contraction. Okay, so place one hand on the fundus. Okay, so what do we do for contraction if the uterus is contracted or not? So we have to place the one hand on the fundus, and then we have to apply the gentle pressure. Okay, and feel for the uterus. If the uterus is soft and it indents, then uterine is relaxed. Whereas if the uterus does not indent, if there is no indentation, then uterus is contracted, and the patient also complains of pain. Now moving on to auscultation, we don't do like a percussion and all. So in auscultation, auscultation for fetal heart sound. Okay, so if the fetus is in occipito anterior position, then the fetal heart sound is best heard anteriorly. Okay, anteriorly, OA position, OAA. Okay, OPF, I remember is like this, OA, OAA, OA and OPF. Okay, so occipito anterior, then the fetal heart sound is best heard at anteriorly, and OP, occipito posterior, then the fetal heart sound is best heard at flanks. Okay, so we can know if it is a left occipito anterior or right occipito anterior and all by the Leopold maneuver. Okay, so fetal heart sound are best transmitted at the fetal back. Okay, so always you have to know the back, if it is by the Leopold, and then you have to always listen, auscultate for the fetal heart sound at the back. As the head goes downwards, fetus also moves towards the midline. So like I said, in the 40th week of period of gestation here above, what I said is, at the 40th week of gestation, the fetus also moves downward. Okay, so we have to auscultate downward, in the downward manner as well. So that are the points that we should keep in mind while doing a obstetric examination. Thank you guys, hope it was helpful for you. Please study your textbooks, and I hope this was a good 15 minutes, like revision video. So yeah, go try it in your patients and in the ward, and the more you palpate, the more you touch, like you examine, uh, the females with the baby, in the fetuses, then the more better you get. So yeah, please do that with all the prerequisites, don't forget that. Thank you guys, this was all. Consider liking the video and subscribing. If there are any like thing that I forgot to mention, or if there are any mistakes as well, so the comments are welcome. Thank you for tuning in. Bye.